Thank you very much, first of all, to ESNO for inviting me to give this keynote talk. It's been a real honour to do this. My name's Bronagh Blackwood, and I'm a professor in critical care at Queen's University in Belfast, and that's in Northern Ireland. And I'm also the president of the European Federation of Critical Care Nursing Associations. And it's on behalf of them that I'm talking to you about the pressures that intensive care nurses are under today. And I've been nursing for over 40 years, and it's always been in critical care in one way or another. I have worked in practice, and then I moved into education, and then from there I moved into a research centre where I'm currently working. And over that time, I've seen obviously a lot of trauma that nurses have experienced over the years. And, you know, when I started nursing, it was back in the 1970s, and that was in Northern Ireland. There were a lot of troubles then. We call it the troubles. It was conflict. There were a lot of bombings. There were a lot of shootings. And is the norm when it comes to things like crises and things like this, that nurses are always at the forefront. They're there at the time when bombs go off, and they're helping the public. They're there in the emergency room. They're there in the operating room. They're in the intensive care units, and they're also dealing with relatives afterwards. And that's going to be the same the world over in conflicts and crises. Nurses just get their sleeves rolled up and they get on with it. But you know, it's not until much later on that it really hits you. The trauma of it really hits the nurses later on. And I think this is what we are seeing as well with COVID-19. So it's not the operating rooms which are absolutely full during this pandemic. It is the intensive care units. And indeed, it's beyond the intensive care units. It's in high dependency units, emergency rooms. Anywhere where there's an oxygen point, you're going to find more patients struggling with COVID-19. And so, no doubt about it, COVID-19 pandemic has posed challenges for healthcare systems right across the world, but particularly for the intensive care units. And at the forefront of the intensive care units are nurses. And so what I want to talk to you about today is the fight that nurses have in relation to the pandemic, how it shows their professionalism, their bravery, and their ability to adapt and to innovate. But also I want to touch on the plight of nurses as well, their vulnerabilities during this time, and also the inefficiencies within healthcare systems that have a responsibility to protect nurses. So how nurses fight the pandemic has been shown very nicely from this systematic review by Fernandez and colleagues, and they brought together a lot of the stories, a lot of the qualitative research from nurses who not only have been nursing during the COVID pandemic, but have also been nursing in other pandemics, for example, SARS, MERS, and also swine flu. And what nurses have been showing from this research is that there's been a strong sense of duty and dedication to patient care, and also for themselves, this personal sacrifice. We all know that nurses care for patients when they're at their sickest and their most vulnerable moments. And yet, even while nurses are doing that, they are afraid they may be afraid for themselves, but they still carry on. And how they do that is that they get immersed in patient care as a way of sort of managing their anxiety and their stress and their pressures. They just immerse themselves in it. And it isn't until much later that that sort of comes out and manifests itself. But there's also, over pandemics, been this great professional collegiality among nurses. There's a great camaraderie. the nurses get together and they share the load, they pull together, and there's a great sense of team spirit. And here you see a picture of an intensive care unit, and for many of the public, they probably have never seen the inside of an intensive care unit, and it's only because of maybe this pandemic that they're now seeing through social media and through television reports what it actually looks like. And they think that, oh, this is absolutely terrible. Look at all that equipment, and look at all those tubes and wires and infusions. But I think what the public don't quite understand is that this is what an ICU looks like even outside of a pandemic. The only difference with the pandemic is this is multiplied many times. And they don't quite understand that there's a big multi-professional team who's caring for this patient. But in my view, the most important person in that multi-professional team is the nurse, because it's the nurse who's by the patient's bedside 24/7. It's the nurse who's seeing the patient through this terrible trauma. So the nurse is not only providing the fundamental care, the personal hygiene, and also holding the hand of the patient when they have the most fear. But I mean, just look at the equipment that's around here. Look at the support systems that are around the patient. The nurse is a highly trained, intelligent professional to also deal with all of this, as well as the fundamental care. And I think people don't quite get that picture of just how much it takes to be a professional nurse. During the pandemic, nurses have shown their ability to adapt and to innovate. And they've done this in numerous ways. I'll just mention a few. In terms of nursing practice, they've been very much to the forefront in facilitating patient and family communication. And indeed, one of my colleagues has been very instrumental in setting up a charity which will provide 4G enabled tablets to all the intensive care units in the UK to allow patients to communicate then with their families, to see their families. They've also thought of innovative ways of identifying themselves, either with their names across the top of their hats or across the top of their PPE, or pictures of themselves and at least their name on the front of their chest, so the patients know there is a face behind here, there's a human behind here, and they can identify with the nurse. In nursing management, there's been massive reorganisation of not only staffing, but care, and also the environment. Things like having runner nurses who deliver resources to each of the bed spaces, and being careful about the use of PPE resources. And in nursing education, there's been swift development and rollout of training programs to meet training needs and to upskill those non-critical care nurses, and very much using a virtual environment as well. But aside from all of that, there's also the plight of nurses who have been affected by the pandemic. There's been this real heightened anxiety for their own personal protection and their safety. And I mean, that's extremely understandable, because they are at greatest risk if they're 24/7 right beside the patient. So it's due to their proximity with the patient and also their exposure to the virus. And it's their exposure over long periods of time at the bedside as well. A recent study highlighted by Arabi showed that over 41 countries, healthcare workers accounted for 10% of COVID-19 cases, with the mortality rates rising up to about 19%. So you can see how much it's affecting personal protection and safety of nurses. But also they have to deal with a lot of dilemmas. And there's a balance between trying to think about caring for patients versus caring for their family responsibilities as well. and they can be torn both ways. The majority of nurses tend to be women, and they also have then caring responsibilities for children as well as for elderly relatives. So there's a balance between working in ICU and what's happening then at home as well, and trying to cope with both of that. There are also some anxieties around the speed of knowledge, how quick information has been coming in. I'm sure everybody has been inundated on their emails about the latest research coming in, the latest guidelines. And there's had to be swift modifications of policies and guidelines of how to treat patients with COVID. And this raises anxieties for staff because they are constantly having to be updated and are fearful in case they're using the wrong policies, the wrong guidelines, because things have moved on with great speed. In terms of staff shortages as well, a lot of nurses have not only been sick themselves, but they could be self-isolating due to COVID within their families. And this has created then inadequate skill mix for high acuity patients as more and more nurses have been redeployed from non-critical care areas into the intensive care unit. So there's a sense of this overwhelming powerlessness because the admissions never seem to stop. They continue on, and sometimes it's a whole ethical debate about who should be admitted, particularly when no beds are left. And planning, it seems to be planning is ongoing and continual, and this is hard to get on top of. But the plight of nurses has also been in relation to their mental and physical health, and they really are exhausted at this stage. There's a lot of stress from the inexperienced nurses who have been brought across to help in the intensive care units. It's a strange, complex, dynamic environment for them, and they feel very inexperienced and are frightened that they'll make a mistake. There are feelings of an inability to cope because it all seems to be too much, and that's even for the experienced staff as well as inexperienced. In many ways, there's a sense of loneliness as well if they're in a room, particularly on their own, and they're there for quite a few hours. We try to reduce the people coming into the room, so that can create a sense of loneliness as well. Sleep deprivation as well, because of the stress, affects alertness and affects performance of staff. And burnout was already there before COVID-19, and Pierre Smith gave a lovely talk yesterday on burnout. But further studies have shown that anxiety and depression is also very high in critical care. COVID-19 also impacts on the quality of care, and I think we don't often think of this. In the intensive care unit, for many years now, nurses have forged ahead to deliver quality of care. And there have been a lot of interest in nurse-led bundles of care to improve delirium and to improve quality of care after ICU. So there have been nurse-led mechanical ventilation weaning protocols. There is less use of sedatives now. There are daily sedation holds to try and minimize sedation so that patients don't become too delirious. There's more interest in having a more awake patient so that they can mobilize early, and there's greater opportunities then for rehabilitation. And of course, there's been this great push towards open visiting, more access for family into the intensive care units, and increased family engagement of care, with some initiatives even looking at relatives helping with mouth care or helping with washing as well. But COVID-19 has really put a stop to all of this, and that's because COVID-19 patients, it's like a whole different generation of ICU patients. They have much higher acuity. Ventilation times have doubled for patients, whereas we saw earlier.
Non, non, bah, prenez-les, c'est bon. Hein.
Pardon? I'm sorry, is there a problem?
I think there was somebody with the unmuted, so sorry about that. You can continue.
No problem.
Thank you.
Okay, I thought maybe you couldn't see my presentation anymore or something. Okay, so ventilation times have doubled. They have gone from about 5 to 7 days, right up to 10 and 14 days, and even longer than that. 21, 36 days is not unusual now to see with COVID patients. They've had to use more sedatives now, mainly because of things like maybe prone positioning, nursing the patient on their chest. Maybe they've had to use muscle relaxants because of the condition of the patient. And therefore, patients aren't being mobilized enough anymore. And of course, the worst thing is, in many intensive care units, there is no family visitation whatsoever. And that is the toughest thing to deal with. And so practice, really, from what I see, it has stepped back nearly 10 years. Just in one quick shot, we've just knocked it straight back. And of course, reversal of these quality of care practices has led to increased duration of delirium and of coma. And this has been shown very well in a multi-center cohort study, 69 countries with 4,500 patients. This was a study that was undertaken and led by Brenda Punn. And Brenda Punn is an advanced nurse practitioner from the United States. And what they did was they collected data looking at the characteristics of patients and looking as well at the interventions that they received in the intensive care unit. And they looked at those that caused a higher risk of delirium and a lower risk of delirium. And what you see on this graph then is the line down the middle is a line of no effect, and all the values which fall to the right of the line show that this intervention is producing a higher risk of delirium, and those to the left are showing a lower risk. And I've underlined some of those interventions which I've already mentioned. Ventilation type, particularly invasive ventilation, puts the patient at higher risk of delirium. Restraint, sedative infusions, and particularly benzodiazepines, and continuous opioid infusions, and the use of antipsychotics as well. But if you see, there's only one on the bottom there on the left-hand side, which leads to a lower risk of delirium, and that is visitation from family or friends. And really, that rarely happens in intensive care anymore. So what's worrying is that these prolonged periods of acute brain dysfunction from delirium are predicting worse long-term outcomes. So for ICU survivors, they have worse outcomes. And this is where nurses are feeling very conflicted, because all of this is necessary to save the life of a COVID patient. But I have to say that the greatest impact on the distress of nurses has to be death and dying in the intensive care unit. The fact that family are not around at the time, and relatives' distress at that. And it's not just relatives' distress, it's the distress of staff. Now, I want to put forward to you some of the key messages that of what the European Federation of Critical Care Nurses feel about this. And this is coming from their views. Now some of you may not know or be familiar with the European Federation of Critical Care Nurses. So I just have one slide to explain about our federation. It's a federation that consists of 31 national member associations, and that's in 28 countries across Europe. It's governed by a board of officers, the president, vice president, treasurer, etc., and also a council of representatives. So one representative from each of those national associations. And we get together twice a year and we plan and deliver education and research projects. And the goal behind these is to promote that collaboration across Europe and equity among the associations to improve care of critically ill patients and their families. And as you can imagine, a lot of our projects have been put on hold during this time, but we have managed to have virtual meetings, and I've spoken to them about this conference, and these are some of the views that they have put forward to me to highlight to you. First and foremost, there is this great fear nurses will not cope with a fourth surge. I'm showing you here these surges just across a few of the countries in Europe, which clearly show the first surge very small, the second one bigger, the third one bigger still. Even in our own national newspaper yesterday, the health minister came out and said a fourth surge is really going to be extremely bad. So if each one has been high, what will a fourth surge be? And this is the greatest fear of critical care nurses. ESNO wants authorities to take responsible action to protect the health and lives, not only of the public, but of patients and of staff who treat those patients. This graph shows the number of COVID patients in intensive care from the very beginning, and you can see there have been, like the cases, these waves. From March, there have been 750,000 ICU admissions worldwide. And the best way to handle a surge in these admissions is to avoid it. So to prevent these overwhelming admissions, we've got to control community spread. And this is what ESNO wants. Authorities to take responsible decisions in relation to their decisions about lockdown linked to what is happening in relation to hospitals. ESNO also needs a European standard definition of a critical care bed, because what critical care means is not the same across all European countries. You can see from the graph on the right, and albeit this was in 2012, Germany seems to have the highest number of critical care beds, 7 times more than Portugal at the very bottom. Now, does this mean that Germany provides more critical care for its population and in Portugal, the population doesn't get access to critical care? We very much doubt this. We think it's more to do with the fact that a critical care bed, there's no common definition. There's supposed to be 11.5 critical care beds per 100,000 of the population, but we think that critical care beds should be defined based on organ dysfunction. It should be based on the level of care, because some of these beds may be high dependency and not really intensive care beds. But alongside the beds, nurses are needed with the skills and the knowledge to deliver and or supervise that level of care. And we've often said this, that ventilated patients require a 1 nurse to 1 patient ratio. We had a position paper from the European Federation, and it was published about 2007. And things haven't really changed an awful lot. There's great disparity across Europe in how many nurses to a ventilated patient. And yet we know from a lot of research that there's a positive association between the numbers of nurses and the chances and the patient's chances of surviving intensive care. So critical care is not just about beds. It depends upon having a highly skilled and also supported workforce. And support for nurses has to go beyond praising them and saying, aren't they wonderful? They're absolutely great. That's not enough for nurses. There's an urgent need for hospital administrators to take seriously the burden that's been shouldered by nurses and the sacrifices made, and invest in solutions. We need reassurance regarding PPE availability for our protection. We need limitation of shift hours to minimize exhaustion. There needs to be a provision of adequate and long-term counselling and support for nurses. There also needs to be follow-up on how clinicians are coping. And we need to have more staff involved in strategies to promote family-centered care, because this is very difficult at this time. We also need substantive discussions about how we're going to attract and retain critical care nurses, because this is going to be a big problem. COVID-19 has exposed those vulnerabilities in nursing supply. The global shortage of nurses is 5.9 million. In the UK, a recent survey showed that 36% of those registered nurses wanted to leave the profession after the pandemic. There's going to be a very large drain, I think, across Europe. We need to have fair pay. We possibly need to consider hazard pay. But there needs to be fair conditions as well, and there needs to be effective skill mix and working patterns. And additional measures need to be put in place to maximise the impact of the quality of care for patients that's provided by non-ICU nurses. There's talk now about a lot of errors being made due to inexperiences, and we need to consider that and support nurses in this. And there needs to be recognition of critical care specialism, and education and training. We should be considering standardized education and training across Europe instead of this bits and pieces and everybody doing it differently. There needs to be more focus on staff well-being, and we need to reduce that burnout. And the substantive discussions I've highlighted here is because we need to have organizations at the table in relation to these discussions. It can't just be a top layer even of nursing leaders. It has to include people who are on the floor. It has to include those at the groundwork. And just finally, I want to end with showing you this wall mural in Norway. This was painted by a Norwegian artist, Pobel, and it shows the Norwegian health minister holding up and supporting a healthcare worker. And this was as a political statement because he felt not enough was being done for healthcare workers during the pandemic. And the European Federation would echo this very much. Thank you.